Fertility. I'm a reproductive endocrinology and infertility specialist and the host of this show. My trusty sidekick Tarek is on the side where he is doing all things web. And we do not have a specific article to review tonight because there's two I want to work on. A lot of people have been asking about the DQ alpha match problem, and so we've started doing some research on that to present that to you, trying to find a good article on that, and I found one, but I want to find some more because it was a bit older. And then there's another really interesting article that is going to be coming out shortly, which suggests that patients who are older may have different thresholds for what a reasonable beta HCG is to consider you positive. So I'll be bringing that to you most likely next week. So tonight, especially because I was on call last night delivering lots of babies, I am going to keep this short and sweet. We're going to dive right into your questions. So feel free to ask your questions now. We're going to start with those. And in the meantime, lots of exciting stuff here at VRC. Our time lapse is up and running and is giving us some amazing images of our embryos, which is incredible. So we're really excited to have that technology. There's no proof that it actually improves outcomes yet. However, it's really good for our workflow. And obviously it makes sense that the less we manipulate those little embryos, the better off they're going to be. So we're really excited about that. We've done quite a few changes. We've hired 2 more nurses as well. So we're super excited to have them join us also. And there's that great conference coming up, the Midwest Reproductive Symposium in Chicago. And 2 of our staff are going to be attending that, so I'm really excited for them as well. I asked if I could go and was promptly told no by the office manager today. So I usually do like to go to that conference, but I've been put in my place apparently this year, so can't go over, but would love to. And it's a great conference if you want to attend either as a physician or as a patient. They have different rates, and it's well worth it. It's a great conference. It's always really fun. Chicago is an amazing town if you haven't been there before. And then on the other side of things, we have been doing a tremendous amount of international work with donors and surrogates and individuals who find out about us online or through our YouTube or our social media. I had someone reach out to me last night from California saying she had bad results and she wanted to come to us now. So we've got loads of people from the States coming across the border, and that's actually really easy for us to manage. So very, very excited about the things that are happening and hoping for an amazing year moving forwards. And of course, the kids are all going back to school, so Wendy and I will be empty nesting again shortly. So yeah, it's going to be a pretty exciting year. My nephew's going to be working with us. Make sure that if you are watching, you follow us on Instagram and join us on Facebook and subscribe on YouTube. Our YouTube channel is full of all of the videos that we do. We always put a copy up on the YouTube channel. Loads of use for our videos there. This year, probably about triple or quadruple what we've ever had before. And pretty much every day we grow by about 10 or 15 followers. So it's been pretty exciting to watch that grow as well. So just go on YouTube and click that subscribe button and follow us. Set for your notifications, and every time we have a new video up, you'll get into that too. Questions? Already? All right, fire away.
Does grading of frozen blastocysts matter for successful transfer, or does the fact that they were acceptable enough to be frozen good enough as an indicator of success?
Now, that's a great question. So we actually reviewed that on the show a while back, and there is a difference in outcomes based on the quality of the blastocyst at the time of freezing and at the time of thawing. So there's no question that better quality blastocysts have a better chance of succeeding, both of surviving the thaw and then of implanting. Most programs have some criteria for what they will accept to freeze. Some programs don't. So for example, Creating Toronto will just freeze everything. We don't. We have a threshold level where you have to have at least a BC quality embryo. So if you get a CC or a CD or a DD, we don't keep those embryos. But some programs keep everything, we do not, because the results are really just too weak to justify keeping them. So yeah, there is an importance in the morphology score of your embryo, both before you freeze and then after you thaw. So before, a 4 is considered kind of the best for the number. And then obviously an AA is the best quality embryo. And there isn't really a big difference between the AAs and the ABs. And even the BBs are fairly similar. But once you thaw it, you want it to begin expanding, which makes it a 5. So when they're thawed, you want 5s. Even a 6 is excellent, but when you're freezing them, you want them to be 4s, maximum 5. 6s don't do great when you freeze them because they've actually hatched out of their shell. So yeah, there is a difference, and that's a great question. So thank you for asking.
On average, how much is IVF?
Oh, okay. So IVF can vary greatly in cost, depending on where you're doing it and what you're doing. So a lot of places will say, well, the IVF costs, let's say, $7,500, but then they charge you for ICSI, and they charge you for freezing, and they charge you for every little thing that they do, teaching and administration fee and all these things. So we didn't want to do that. I didn't want to nickel and dime people. So we actually set our pricing as just a package. So we don't make people pay for this or pay for that. We just say, here's the price for your package, and we just include everything in the package. So your freezing, your IVF, your monitoring, your first embryo transfer, your laser hatching, your growing till day 5, even the time lapse, we've included in our packaging. Most places charge an extra $1,200, $1,500, $2,000 for time lapse technology. We actually just absorb it and build it into the cost of the package. So you just come in and it's one price for our package, and it has everything that's included there. So on average for us, like a basic package for a couple is about $10,745. And that includes everything you need except for your medications. So that's all of the stuff that will get you to an embryo transfer, through your embryo transfer. It just doesn't include your meds. And it includes freezing up to 8 of your embryos for the first year. For couples that want guarantees or they need duo-stim, we obviously have different packages. We do a lot of guarantees because people want us to put our money where our mouth is. So they basically want to feel that they can trust us. And for that, we offer money-back guarantees. So if we can't get you pregnant, there's a small administration fee and you get the rest of your money back. They're great programs. Obviously, there's qualifications, but a lot of our clients choose those because they want that reassurance and that comfort. Other centers can be more, and I'm sure somewhere there are centers that can be less. But you know, depending on how lean you're keeping it, you're potentially compromising patient care. There's only so much you can do when you're saving money. And so we kind of set it at the limit of what we thought was reasonable to be able to provide you with the best service possible, constant communication, amazing people on our team, and then at the same time have it at a cost that's reasonable for you and allows us to pay those people what they deserve so they can continue to be amazing. So there is a balance there, and we need to kind of make sure it's reasonable for everybody.
What are the implications of PCOS on IVF? Does it mean we will have a lower quality eggs even if we take NAC, CoQ10, prenatals, vitamin D, and omega-3?
And inositol, make sure you're taking inositol if you've got PCOS. No, not necessarily. So women with PCOS can have poorer quality eggs, but not always. And especially if you're taking the supplements, if you are monitoring your sugars, if you're on metformin, and importantly, if you are driving your weight down, then you can very much have a reasonable outcome under those circumstances. And if you do a cycle and they don't overstimulate your ovaries, you can actually get very excellent egg quality from it. The problem comes up when they overstimulate you. You start making 50 eggs, 40 eggs, very, very high numbers with super high estrogen levels. And you're not dealing with the other elements. So you're not on the holistic part. You're not on the supplements. You're not managing your weight or your diet. So yeah, that can compromise the egg quality. But generally speaking, it's not a really huge issue for us. Our PCOS patients do very, very well when we do their IVF cycles.
For someone that is just planning on getting tested and such, I'm not planning on going through the process for 2, 3 years right now.
Okay.
I currently have an IUD. Would I have to have that removed before going for testing?
No, not necessarily. It depends on what testing you want to do. But I guess my question would be, why are you testing if you don't want to do anything for 2 or 3 years? Unless you're worried about your ovarian reserve. I will say in the fertility world, 2 or 3 years is an eternity. So for example, if you're 35 and you're thinking of waiting 2 or 3 years, that's actually a bad idea. Because you will see a very significant difference between your success rates at 35 and your success rates at 37, 38. Even more so if you're 37 and you're thinking of waiting 2 or 3 years, that's a terrible idea. But if you're 27 and you're thinking of waiting 2 or 3 years, that's perfectly fine. So it depends on where you're at right now. But no, you don't necessarily need to have your IUD removed. We can do some of the testing. Some of the hormones may not be exactly where we anticipate they should be or reflect what you would be off of the IUD if it's a hormone IUD like a Mirena or a Kyleena.
When you talk about advanced age, is the egg provider or carrier when you are talking about surrogacy?
Huh?
I read them. I don't write them.
So when we talk about advanced age,
Is
we're
that the egg
reflecting
provider?
the egg age. The age of a carrier is irrelevant. I mean, you can get a 60-year-old or a 70-year-old pregnant. I had this adorable Asian mom once who carried for her daughter, and she carried twins, and she was 53 when we did it. I just had a mom who was 52 do it for us. I've got a 62-year-old patient that's willing to do it. So the woman's age, I mean, it has some impact, but it's generally pretty minimal. The more significant feature and the more significant issue is making sure that the egg age is a reasonable age. So, for example, if you're 32 and you're putting your embryo into a 45-year-old, that's totally fine. We do that every day, all the time. But if you're 45, putting your embryo into a 32-year-old, that obviously has a drastically reduced chance of success because of the fact that the egg age is 45, and the majority of those are going to be genetically not normal.
Thoughts on a day 7 embryo?
Yeah, so there's good data on day 7 embryos. Gosh, I think we've reviewed it, but it was ages ago on the show. It'll be on the YouTube channel. Go to YouTube and subscribe. So it is not as good. In fact, it's drastically reduced compared to what you get from a day 5 or day 6. As a general rule, there's only about a 15% implantation rate with day 7s. That's a gross kind of generalization, but those are the numbers that they provide in the studies. And they have done studies that have looked at what the outcomes are for day 7 embryos that are genetically normal. And even when they're genetically normal, they have a lower chance of sticking. So it's not quite as good as the day 5s and the day 6s. Still usable, still should be used because there is a chance, but it's a modest chance. It's not like what you're going to get from a day 5 or day 6 at a good center.
Would you consider doing back-to-back dual stem cycles without doing a transfer in order to freeze embryos at my age, 38 years old?
Your age is not the criteria we look for duostim. It's your ovarian reserve that's the issue. So if you're a 38-year-old with a high AMH, you may not need duostim. And in fact, it can kind of cause a mild hyperstimulation sometimes. So we don't always push it for everybody. But if you're, whatever age you are and you are struggling with ovarian reserve issues, then duostim is always a great idea. Now, when you say back-to-back, I don't know if you mean follicular phase retrieval, luteal phase retrieval, and then another follicular phase, and then another luteal phase. there's no reason why you couldn't do that, although your cycle will get very messed up. So you won't know what's coming and going. But we do know that eggs come in waves, so you can kind of repeatedly stimulate people to get them to produce eggs. That's not an issue. I'm not sure I would try that. I'd probably give you a month in between. But there's no reason why you can't stim someone over and over and keep getting those cohorts of follicles.
How important is the thyroid level during an FET cycle? What should the thyroid level be to optimize FET success and a miscarriage?
So your TSH should be less than 2.5. Your T4 should be in the normal range, depends on which lab you're using, but usually from like 8 till 22. You should have no thyroid antibodies. And how critical is it? It's immensely critical. We check it on every single patient. So make sure that you are having that checked. It's really important for you.
Thank you. You and your team took care of me this morning when I was in horrible pain and did an amazing job helping. Thank you so much for your care and help.
Are you better? I was totally worried for you. My contribution was covering you with that nice fuzzy warm blanket, but let us know if you're better. I hope you're better, and I'm sorry you were so uncomfortable this morning, but I'm glad you're better, at least enough to write to us. So let us know how you're doing. I'm sure everyone here was quite worried about you, so let us know. Just for clarity, in case everybody else is watching, this patient came in today with significant discomfort, but it did not have anything to do with any of the treatments we had provided her with. So we were just helping her through a rough time.
Hello, Dr. V. Thank you for doing these amazing Q&As. Can I ask what you'd like to see as far as TSH levels? Mine was 2.7, and I'm concerned that may be a reason why my recent FET failed.
2.7 is borderline. It's supposed to be less than 2.5. That's from the Endocrine Society guidelines. So you are supposed to keep it under 2.5. I don't know that I'd adjust to 2.7. I mean, that's so close. That's probably within the lab error, but I wouldn't be concerned unless you had a low T4 or you had antibodies. So again, I never just use the thyroid number. You really got to look at the rest of the picture. The TSH alone is not enough. You need the T4, you need the antibodies. Because sometimes if you've got a TSH of, let's say, 1.9 and you've got really high antibodies and your T4 is only 12, there's room to give you some thyroid stimulation to drive down the antibody levels. And that is very important. So just taking one number is not enough. You really have to have a very holistic approach to this.
My period used to be 28 days long, and more recently it started to be 31, 33 days long. What could be the cause of this? Will it make it hard to conceive? Thanks.
That subtle a change shouldn't make it harder to conceive. If you start going like really short cycles, 21 days, 22 days, 23 days, or really long ones, 34, 35, that can. But not a subtle change like that. If you're a 31-day cycle, you're still ovulating on day 16, 17, so that's reasonable and your egg quality will still be good. Why could it be happening? 100 million different things. Physiological changes, change in your weight, change in your diet, stress, COVID, vaccination, weight gain, weight loss, exercise amounts. There's all sorts of different things. So it's not like one thing that we can point at.
A lot of numbers. Get ready.
Okay. Should I get a pen and a paper? Do I need that?
I don't know.
All right.
I can't
I
read.
am very sleepy from not sleeping all night, so you're challenging me here, but go for it.
Hi, Dr. V. This is my PGS test results.
Okay.
7Q31.1, Q32.2, 19.1 MB, 40%, 7Q32.2, Q36.3, 29.5 MB, 40%. What are my chances?
So that sounds like there is deletions in your chromosomes So that's very complicated. You need genetic referral before anybody can answer something like that. So I'm listening to it, so I'd probably have to see it to understand it. But if it's what I think it is, you either have an addition or a deletion in the arms of the chromosomes, and if that's the case, then depending on how big it is and how important it is and where it is, it can very significantly alter your outcomes. So you definitely need to talk to a geneticist about that before proceeding. There are ways to screen out those portions, or not those portions, those embryos that are affected, but it depends on what exactly is going on. That was a lot of numbers.
Yeah, believe me, reading it was a challenge. Is back-to-back IVF stimulation cycles beneficial for embryo banking? Is the success rate any better?
To the best of my knowledge, there's no evidence that embryo banking per se improves your success rates. Now, it depends. Obviously, if you're, for example, 38 and you do one cycle of IVF and make 10 embryos and spend the next year going through those 10 embryos and then have to start again, you're now 39, yes, there's going to be a decrease in success compared to I did one cycle of IVF, I made 10 embryos, I froze them all, and then we made another cycle of IVF a month or two later and froze 10 more. So the timeline really has a huge impact on the results and the outcome. But again, it depends on your age, your embryo age, all of the different factors that are going into it. So I would say in the overwhelming majority of cases, you do not need back-to-back cycles. And if people are promoting that, they're promoting it to make money. Having said that, there are some instances, in particular when age is becoming a factor and the patient wants more than one child, where embryo banking is not just useful, it's imperative. So if you're, I don't know, 39, 40, and you want to have 3 kids or 2 kids, you need a lot of embryos. So doing it once and then trying all of those embryos and going through a year and trying again is not nearly as beneficial or successful as banking embryos in back-to-back or even slightly spaced out cycles and then going ahead and doing the embryo transfers. So that's a great question. We've never been asked that before. So thank you for that question. Lots of thumbs up and little hearts and all that fun stuff.
How soon after FET can you fly? Our clinic is a 2-hour flight from where we live versus a 15-hour drive. Thank you.
Wow. Okay, so first of all, I'm sorry it's so far. In theory, there's no reason why you can't fly. Having said that, if you're flying from Toronto to Windsor or Toronto to Thunder Bay or something like that, those are non-pressurized flights. Well, Toronto Thunder Bay can be if you're taking a jet, but the non-jets are non-pressurized. So those probably have less of an impact. If you're flying from, let's say, Toronto to California, or you're flying from Toronto to Europe or something like that, obviously that's going to have more of an impact. How much? We don't know. No one's studied that per se, but there are oxygen pressure changes which your body is not used to, and certainly your pregnancy would not be used to. So it's probably something we try to avoid, but no one really actually knows the answer to that. So it's a good question, but we don't know the answer yet.
Thank you so much for always answering our questions.
Oh, my pleasure. Thank you for asking your questions. They're always good questions. I've been telling everyone lately that I love doing this show because it actually forces me to stay on top of everything. So your questions are great because I pride myself on trying to be knowledgeable and being able to answer people's questions. And we get asked questions where I go and look stuff up. So, I constantly review. I constantly try and explore. I'm always looking for newer information so that I can help people with more answers and more questions. So yeah, I mean, the questions are great because it keeps us all sharp and keeps us all very honest. If you don't know what you're talking about, it's recorded. People are going to see it. So it's important to know what's going on.
I got a new question for you.
New question. Like, as in, we've never had this question?
We've never had it. Like, I can't answer it.
As long as it's not that is rough sex.
No, it's not that one.
Because looking up okay, so once upon a time we got asked if rough sex decreased your success rate. So naturally, being the research guy that I am, I decided to look it up. Yeah, looking up rough sex and fertility is not a good idea. It's definitely not PG-13. So as long as it's not one of those questions, we're good. Fire away.
Does the book, It Starts with the Egg, offer any good advice?
It does, to the extent that it's true that it partially starts with the egg. It starts with the sperm and the egg, so I think it's a little biased. But to the extent that it says do everything humanly possible to improve your egg quality, sure. Unfortunately, I think it misleads people into thinking if I take a bunch of vitamins and supplements, I'm going to naturally get pregnant when I've had years of trouble. And that's probably not accurate. Does it work for some people? Yes. Is it working for everybody? No, or else I wouldn't exist, or fertility centers wouldn't exist. That's a very well-known book read by millions of women. So the question is, what percentage of women that go out and do everything that's said in that book end up pregnant naturally? Not nearly as high as you would want it to be to say this works all the time. So yes, it can be beneficial, but it's not definitive in the sense that it may take you from getting a 50% success rate to maybe a 55% success rate, maybe a 60% success rate, but it's not going to take you from 0 to being a 60% success rate like IVF can. So it's an adjunct. It's something that we use to help, and I'm a big believer in all of that stuff. I promote it openly on the show every week, but I don't believe that it's sufficient in and of itself. So I'll give you the best example I can. This has nothing to do with fertility, but it is a good example. Years and years and years ago, I had a lady that presented to me who had a fibroid in her uterus that was roughly the size of a basketball. I mean, it was absolutely enormous, probably even more a beach ball. Like, this thing was gigantic. And I said, not only do you need surgery, we need to block the blood vessels first. Like, this is major. You need this taken out. It could be really bad. And you're going to need to be done by gynecologic oncology, because they may need to do very extensive surgery for you. You know, look at the ureters, the blood vessels, all this stuff. So she said, no, I'm going to go and I'm going to use vitamin C, and I'm going to use vitamin C to treat my fibroid. Now, first of all, there's no data that says vitamin C will shrink fibroids. But even if there was, in the best case scenario, using something like Lupron, which literally turns fibroids off temporarily, you're only getting 50% volume shrinkage. So a fibroid that is, 30 centimeters like this one was, is going to end up being like 25 or 26 centimeters still in diameter. It's massive. So yes, you've shrunken it 50% of its volume, because it's 4/3 pi r cubed for the volume of a sphere, but you still haven't made much of a dent in a giant fibroid. It's still enormous. So, supplements and things like that can help, but at the end of the day, if you need surgery or you need IVF or you need IUI, then that's what you need. They're going to get incrementally better by doing these other things, the acupunctures and the holistic health things. And again, I'm a big believer, because I believe the healthier you feel you are going into it, and realistically, the healthier we make your eggs and your sperm, the better off your chances are. But is that enough to turn the tide or make all the difference? No, it isn't. And it's unrealistic to expect that it would be.
Do you take patients from Toronto? If yes, how does it work?
We do. So I have practices in Toronto. In fact, I'm trying to negotiate taking over one now. And then I have colleagues that I work with. I have centers that I have privileges at. But the reality is, in one sense, and one sense only, COVID has taught us some lessons. And that is that more than ever, infertility truly can be not just local or slightly distant local, but international. I mean, we have patients I've got a patient coming to us from the Netherlands. We've got patients coming to us from every country in Europe. These are patients who aren't just looking for egg donors and surrogates, but are actually bringing their egg donor with them. And they're using the wife or the partner as the gestational carrier. So there's no concern with where you are. I have loads of patients in Toronto. We just gave news to several of our Toronto patients. All of them were pregnant. So, this is not a big issue for us anymore. Testing can be done anywhere. Treatment can be done anywhere. And Windsor to Toronto is super close. But if you want me to do your IVF or your IUI in Toronto, we have loads of places that we can offer that at. Yeah, we're really kind of already multinational, and certainly in Canada, it's easy to treat people. I was on the phone last night with a couple from out west who really did not get good care at all, in my opinion, and really need help to be guided to what they need, and they hadn't received that yet. So I offered to help them for free because they'd already been put through the ringer, and I just want to help people. So. We do what we can for everybody, but you don't have to be here. Zoom kind of fixes everything pretty much, and testing can be done anywhere.
If you have normal ovarian reserve, normal retrieval numbers, 16, and get one blast out of 2 cycles, is the genetic issue likely?
Well, there's a whole host of features that can go into that. So it could be sperm quality, it could be egg quality, or it could be the lab. So if it's egg quality, it could be all sorts of different things: smoking, drinking, drug use, your weight, your vitamin intake, your nutrients, your dietary habits, your genetics for sure, the potential for infection, although that's pretty slim. If it's sperm, the same thing: diet, weight, body mass index, your vitamin intake, the frequency of ejaculation, your sperm DNA fragmentation. If you're a guy and you're a smoker, drinker, drug user, you can kill your fertilization, your blastocyst development, and for sure implantation. And then, one of the things that's overlooked, and I've learned this the hard way from working in other centers, is the lab. So if you don't have a top-notch lab with someone who bleeds tears when it doesn't go well, you're not going to get top-notch results. So, the last center I worked at, the embryologist swore that he was the best in the world, and he was very, very good. Was he the best in the world? No. Would he listen when I wanted to change things or make things better? Absolutely no, which is why I left. So, there are centers where they accept a threshold here, and other centers where they accept the threshold here, and other centers where it's at the top. I'm proud to say that, my embryologist and I, who really work as partners, don't accept anything less than the best. So if it's not amazing, she's angry at herself and angry at everything, and she fixes it immediately, and so do I. So I think it's really critical to recognize that sometimes it's actually not you, it's actually the lab. I spoke with a couple from Slovenia recently. She went for her egg retrieval multiple times, and she doesn't have very good ovarian reserve, so they're only getting one egg. And they couldn't even get the one egg. Like, she had one follicle develop, but she'd go for the retrieval, they'd pop in the needle, nothing, and pull it out and say, we're done. I mean, we flush sometimes 5-6 times in a follicle to get the egg out before we call it quits. So, if we have a patient with less than 10 eggs, I do everything I possibly can. So we had one, I think it was this morning or yesterday morning, and we had, she was supposed to have only 10 eggs, and we got many more than the 10 eggs because I spent all my time flushing every single egg out. So we not only got all of them, we got every single follicle that was there. So yeah, I mean, it depends on how hard you're willing to push, and that's all the lab and the doctor and making sure they're doing everything possible for you.
Thoughts on grade 3 and 4 eggs?
Grade 3 and 4 eggs. Most places don't grade eggs, so I'm not sure what you're referring to when you're talking about grade 3 or 4 eggs. If you mean a 3 blastocyst or a 4 blastocyst, 3 is okay, 4 is great. But eggs we don't normally grade per se, and it's hard to get consensus on egg grading, so that's why most people don't do it.
What is the testing process for new patients referred to you that have been referred to you?
Yeah, so history and physical first, and we're very extensive. I mean, I ask you everything. So then we do comprehensive testing for both of you. So that includes hormones, natural cycle monitoring, a saline infusion sonohistogram, sexually transmitted disease screen, in some cases a drug screen, and vitamin levels, AMH, we do check your vitamin D level, ferritin, those sorts of things, progesterone level. And then for the guys, kind of the same thing. For both, we look at cholesterol, sugar, insulin levels, all of that, comprehensive hormones. We look at your STD screen for the men, and then we do a semen analysis, and our semen analysis is very detailed. We actually incubate the sperm overnight to see how many of them survive, which is predictive value for success with IUI. And then we move it one step further, and in many cases we do sperm DNA fragmentation, which has good evidence that it has a significant impact on your outcomes. So that's our basic testing. In some cases we go further, it depends on what the history is. So if you have recurrent pregnancy loss, there's a lot more testing. If you previously tried elsewhere and you failed, we have lots of testing that we offer those patients as well.
What do you look for from blood work results to determine LH surge has happened?
Every center is different, but you're looking for a spike in your LH. Different places use different values. Some places want to see a certain percentage rise. Other people use a hard number. Typically, you just want to see the LH kind of suddenly spike up, and then you know that it's an LH surge.
Big question.
Big question. Okay. It doesn't have more Q's and P's and
no. Just
19 megabyte deletion.
Easy to read words.
Okay. Fire away.
Hi, Dr. Victory. I am on day number 12 of cycle. Been taking ovulation tests since day number 8, twice a day, and the tests are not coming back positive.
Oh my God, that's way too much. Stop testing twice a day. Okay, go on.
My normal cycle is every 26 to 28 days for 7 days.
Okay.
When should I start to be concerned about ovulation not happening?
Well, ovulation is fixed at roughly 14 days back from when you start your next period. So I know that sounds confusing, so let me explain it to you. So let's say your period started today, you ovulated 14 days ago. If your period started a week from now, you ovulated 1 week ago. So it's always 14 days back from the start of your next period. So if you have a 26 or 27 day cycle, 27 minus 14 is 13. So there's always some leeway in there, maybe plus or minus a couple of days. So if you're out at like day 15, 16, 17, and you still haven't ovulated, then you're not likely going to ovulate in that cycle.
I'm over 30 and never been pregnant. What are the chances of helping me have multiple birth twins? Smiley face.
What are the chances of helping? Yeah.
What are the chances of you helping me have a multiple birth?
Yeah, the chances are 0. I wouldn't do it. It's dangerous. It's unsafe. There's all sorts of complications. It's an 80% divorce rate. We don't try to make twins. Look, twins are adorable. I get it, and it's lots of fun, and everybody thinks it's a blast. But it's a super high-risk pregnancy. It's super complicated. You can end up with maternal complications, high blood pressure, diabetes, preeclampsia, toxemia, ICU admission, massive hemorrhage, C-section, and wound complications like the blood clots. The list goes on and on and on and on. And then there's fetal risks, most of which is surrounding prematurity. A lot of twins are born early, and if they're born early, they can have very significant health problems. Anything from, nothing all the way out to, God forbid, death. So we don't try to make twins, and you shouldn't be aiming for it ever.
Does your clinic have an immune protocol, and what criteria do you use to determine this protocol?
Yeah, we do. We have several immune protocols, and it's tailored to whatever's wrong with the patients. So, like a garden variety immune protocol might be just steroids and intralipids plus minus heparin. We use aspirin in everybody. More significant might be subcutaneous IG therapy. We use lit therapy if it's indicated, and we have the advice of a reproductive immunologist for that. And then tacrolimus is available. There's all sorts of different things that we use. We use whatever is indicated and whatever we think is going to give us the best chance. How do we decide? Recurrent implantation failures, recurrent miscarriages, negative tests on everything else, and it's unexplained. Sometimes we'll look at your immune system, and we use Fertility to do those tests. Not because I think they do a better job than anybody else, they're just cheaper. And I hate people wasting money, so we use them.
Would you take a patient from Montreal, Quebec for IVF?
Yeah, of course. I've actually got patients from Quebec for IVF. Yeah, absolutely. Listen, we want to help everybody. I don't care where you're coming from. I have patients from Saskatchewan. We have patients from Quebec. We have patients from Newfoundland. We've got patients from out of the continent, literally the opposite side of the world. So it doesn't matter where you're coming from, we'll help you because we're here to help people.
Is having early 4MC in 2.5 years without having a full-term pregnancy normal? What can be the cause? No endo, no PCOS, no thyroid, and no vitamin deficiency.
Okay, so that questioner is saying, is it normal to have 4 miscarriages in 2 years? Probably not. The current guidelines say that if you've had 2 in a row, you should be investigated. The old guidelines said 3. Everybody would agree that at 4, even at 3, you should be tested. What are the possibilities? Infection, immune system, genetics, problem with the shape of your uterus, fibroids, polyps, hormonal problems, substance exposure, smoking, drinking, alcohol, drug use, and then there's the weird stuff that not everybody believes in, and there's not even proof for, but the weird mismatches and things like that. So, and then sperm DNA fragmentation for the guys, male age, male social habits, all of that stuff factors into it as well. So it's not all female. So yeah, there's a whole bunch of different possibilities, and you definitely should be talking to one of us to get a comprehensive investigation. I forgot to mention blood clotting, so thrombophilia screen as well.
My FET is in about a week. What tips would you recommend for a successful transfer?
Well, we've reviewed our frozen embryo transfer protocol enough that by now I think the whole world should be following it. But so we're Lupron, letrozole, antibiotics, probiotics, loads of vitamins, loads of supplements, melatonin, vitamin D, ferritin, in many cases inositol, NAC, curcumin, depends on what your history is. Definitely 2 types of progesterone, vaginal and injectable. It's absolutely clear that you need that. We definitely follow your progesterone levels, and we want to make sure that the right things are happening in your uterus once you start the progesterone. So those are the basics. So on your end, you can demand those things, and then some of them you can do on your own. So melatonin, vitamin D, baby aspirin, probiotics, all of those can be done by you. Eat healthy. The Mediterranean diet has been shown to improve success. Keep your weight down, exercise, pray, meditate, yoga, acupuncture. All of these things have been shown in some studies to have some benefit. So that's really easy stuff for you to do. And then the other part of it is what to do afterwards. I'm going to beg you to stay off of Google, Because the worst thing you can do is go on Google and start looking up every single twinge that you have, because it's going to turn you into a nervous wreck. What happens then? You release tons of cortisol, it activates your immune system, and now you're killing off your embryo. So do not go on Google. Stay off of Google. Go get a book, read something, bake something, go back to work, enjoy time with your family, start a business. I don't care. Just do not go on Google.
Is it okay to exercise 6 days a week, 50 minutes, 1 hour a day, moderate, high effort, strength training, and spinning when trying to conceive?
No. That's way too excessive. So you want the blood flow to go to your uterus and ovaries, and that's hardcore workout, so that's way too intense. Slow that down.
How do you treat women with a low AMH and a high FSH with an AFC of 4 to 9, age 39?
With respect and kindness, as we do all our women. Yeah, that's a good question. So those are patients where there is a discrepancy in your findings, but you got to look at the whole picture. So an AFC of 4 to 9 is not particularly high. So regardless of what your AMH may say or your FSH may say, you really need to be on the ball and look at a protocol that's going to at least anticipate a reduced number of follicles. So we would treat those patients like they have diminished reserve, because if you treat someone like they have diminished ovarian reserve and they end up producing lots of follicles, you can always slow it down, right? Give them less dose, back off some of the stuff, and you won't get as many eggs. But if you treat someone who has diminished ovarian reserve like a normal patient and you don't give them enough, or you're not being attentive to what's needed in their specific protocol, use a protocol that will help push the ovaries to make more eggs, you've missed the boat and you can't catch up. So, and the places that do catch up are doing it wrong, because we know that the duration of your stimulation is related to how well you succeed. So you want to try and minimize the duration as much as humanly possible. So yeah, that's a great question, but make sure you focus on the whole picture.
Next question is from Europe.
Woo! Europe! Oh my God, you're up late. I'm sorry. Okay, fire away.
Is having 4 early miscarriages within 6 weeks normal? Trying to conceive for our first, all our hormones are good, no thyroid, no vitamin deficiency, no endo,
I think
no
that's the
PCOS.
same one.
33-year-old and trying to conceive since 2019.
Is that the same one that asked it before? Maybe she asked on 2 platforms. So no, anytime you've had 4 miscarriages, it's not normal. So you need an extensive workup. You need to be evaluated. You need to figure out what's going on. So like I said, there's a whole variety of possibilities: infectious, immune, genetic, thrombophilia, shape of your uterus, your hormones, like the list goes on and on and on. But you need a workup to see which one of those it is, because what you're going through is not normal, and it's actually not good for you to keep having recurrent miscarriages, because it does increase your risk of breast cancer. So please, please, please get seen. It is critical that you get checked out. And if you don't have help out there, reach out to me and I'll help you.
10 minutes.
10 minutes?
I'm giving a 10-minute timer.
Awesome. Fire away. Are we at 8:50? Oh,
yeah.
At 8:50. Cool. All right, man.
I'm worried about my husband's daily alcohol intake. He absolutely refuses to quit. Curious to know what you would say to him on our first appointment.
Alcohol is not good for you. So I would tell him all the facts. And sometimes I get creative about it. So let's talk about the facts about alcohol. Alcohol is a class 1 carcinogen. It is known to cause 7 types of cancer and 4 more suspected, but highly likely. So if you have more than the recommended dose of alcohol, which for a male is 3 to 4 drinks per week spread out throughout the week, you are increasing the risks of cancer in that individual. So that's number 1. Number 2, shrinks your testicles. Number 3, increases the number of abnormal sperm by 83%. Number 4, alters your sperm DNA fragmentation testing. Number 5, 2% increase in the risk of congenital heart defects in the baby if the dad is drinking 2 glasses of anything per day. So all these things have an impact. And then the last part, if that's not convincing them enough, is very simple for me. Right now, the whole world is inundated with one thing and one thing only, and that is hand sanitizer. Why? Because we're all trying to kill COVID and bacteria and viruses so we can get out of this damn pandemic, right? So what did we end up doing? Everybody said, wear your mask, wash your hands. Wear your mask, wash your hands, wash your hands, wash your hands. And yes, the masks are important. I'm not going to get into that debate. But washing your hands is actually even more important, right? So you got to wash your hands. What do we use to wash our hands? We use hand sanitizer because not everybody has quick access to soap and water, but the hand sanitizer is easy. You rub it in, it kills everything, right? It says on all of them 99.99% effective. Why is it so effective? Because it's incredibly powerful at killing live material. What's in it? Alcohol. So what are you actually taking into yourself? You're taking in stuff that we use to kill biological material. When I used to work in a lab at the University of Michigan or the University of Toronto, when we had to clean the countertops at the end of the day to make sure we got rid of all the bacteria, all the cells, all the viruses that we worked with all day long, we cleaned with ethanol. It's literally the stuff you're drinking. So why would you put something you use to kill tissue with into your body? It's literally killing you from the inside out. It makes no sense. Sorry. And I know lots of people feel that they can be responsible drinkers, and maybe you can be, but it's terrible for fertility, and there's absolutely no question about that. There's another article just the other day talking about alcohol and outcomes, and that it increases miscarriage risks. So do not drink while you're trying to conceive, and that goes for the guys too. So I hate it when I see that women are always the focus of everything in fertility. Yes, of course, you have the lion's share of what's going on, but the guys have a huge role as well, and it's not like they can do whatever the hell they want and get away with it. It doesn't work like that. It doesn't work like that at all.
So you have a follow-up to the question with the IUD. So I want to have an idea of what's wrong. I've tried to get pregnant for 1.5 years and had no success. So I want to get tested to see if there's anything wrong. I'm 26, but want to look into getting tested to see what my options are. Like if I can have if I can try natural. So I wanted to have an idea earlier. I recently got an IUD like half a year ago, but was curious about how the testing would work with an IUD.
Yeah, we can test you. Like I said, your hormones may be a bit screwy, but we can do the rest of the testing. The IUD can sit there, it won't impact me. I can tell if your tubes are open, if your uterus is normal. Most of the hormones I can get won't be affected by the IUD. And then, of course, your partner stuff won't be, your sexually transmitted disease screen won't be. So it's not a big deal. We can get a reasonable semblance of what's wrong. A lot of times we can figure it out from just your history. Probably about 10% of our patients get pregnant just from coming to see us before we even do any therapy, from just the testing, because we figure out what's going on along the way, and they actually get pregnant while we're figuring it out. So it's super common here, and we love those ones. Those are the drive-bys. They come in and they get it and they're gone. So those are awesome.
Like the drive-by term.
The drive-by, yeah.
If the carrier has undergone genetic carrier screening, is young and starting IVF, is it okay to omit testing the embryos, or is it still recommended?
If your carrier
has undergone genetic testing.
Carriers don't need to undergo genetic testing. So if you're using somebody else's eggs and they're young, you don't need genetic testing. If you are young and you're carrying, then you also don't need genetic testing, unless there's a family history or something, obviously. If you're using an egg donor and you're whatever age you are, you don't need testing. She definitely needs comprehensive carrier screening, which is where we check for like 300 to 400 different individual genes. But she doesn't need a karyotype, and you definitely don't need PGTA on your embryos, where we check the embryos to make sure they're normal. That's been proven to be useless, and we reviewed that on the show 6 weeks ago,
Yeah.
2 months ago, something like that.
Less than 3 months for sure.
Yeah. Yeah.
Doctor, after not being pregnant for over 20 years with unprotected sexual intercourse, how much is it going to cost for an egg donor?
It depends on which agency you want to use, or if we find you someone private. So in Canada, you're not allowed to pay egg donors for the donation. You are only allowed to cover their expenses. So it depends on their expenses. Most of the time, their expenses are going to come out to being somewhere around the neighborhood of $5,000. Could be cheaper, could be a little bit more. Then if you're using an agency, there are agency fees, and that's a separate issue altogether. So at a minimum, I'd say probably around 5 to 7,000. The highest I ever heard of was this agency we refused to work with, which was just blindly gouging people. And that was $23,000. That's absurd. Nobody should be paying $23,000 for an egg donor. That's crazy.
This is my first time here. What a great opportunity, Dr. V.
Welcome.
My day 5 after Gonal F250 and Menopur 150 has my level at 1398.
Cool.
Now I've started Cetrotide today. I'm worried things are moving too fast.
No, I mean, day 5 or day 6 is frequently where people will start the Cetrotide. I'm not sure why you were started on Cetrotide that early. It depends on the size of your follicles, and to some extent your estrogen level. I wouldn't start it based on your estrogen level, but certainly if it was started because your follicle sizes were large, that's something to take a look at. Can you go too fast? Yes. So make sure they're not overstimulating you. But yeah, I mean, that's a reasonable start, and depending on how many eggs you have, it actually sounds kind of promising. So you're off to a good start.
If your eggs mature fast, will IUI work?
If your eggs mature fast, will IUI work? The IUI has nothing to do with the speed of the maturity of your eggs. However, if your eggs mature too quickly, so you're releasing on day 9 or 10, your lining doesn't always have time to catch up. So realistically, you may have everything you need in terms of ovulation, but it may not work because of the fact that you're dealing with a lining that hasn't caught up to where the egg is, or the egg is not in sync with the lining. So those can make it a little bit more difficult.
I have more than 1,000 in thyroid antibodies and normal TSH, diagnosed with unexplained. What can you recommend to help decrease antibodies? Thoughts on Lugol's iodine?
So I'm not familiar with using Lugol's iodine for thyroid antibodies per se. Obviously, the thyroid hormone needs iodine for production, so that they're integrated together. However, the first thing to look at is your TSH, your free T4. So if there's room to stimulate your TSH without overdriving your T4, that's where you start. Then you should probably be talking to a naturopath, because they can do some natural things to reduce your body's overall inflammation, which will reduce hopefully the antibody production. And then selenium, and I just learned last week with Dr. Laura Jasmine, our naturopath in Sarnia, that inositol apparently can do it too. And she actually sent me an article, which I should look up, saying that it does reduce the incidence of thyroid antibodies. Let's see if I can find it here. Laura Jasmine. Where is it? Here we go. Myo-inositol plus selenium supplementation restores euthyroid state in Hashimoto's patients with subclinical hypothyroidism. So there is some evidence that it can help. So inositol, we've always used selenium. I didn't know about inositol, but now I do. So yeah, try those things. Naturopaths are great, so talk to them. All that stuff can work.
9 o'clock, 9:01.
9:01, we're done. I'm exhausted. Okay, So listen, thank you very much for joining us. If your questions did not get answered, come back next week. We will happily take you. And make sure you tag us or get some friends to follow and send us a message and say, hey, all these folks followed, and we'll answer your questions for sure. Make sure you subscribe on the YouTube channel, and we will bring an exciting show for you next week, because I think that info on age making a difference in terms of what is a positive and negative beta, or a predictive of a good outcome, positive, negative beta, is a really cool concept that nobody has looked at before. So we'll talk about that next week. And in the meantime, please, for the love of God, if you've not been vaccinated, get vaccinated. I hope you're all well. Stay safe, guys, and we'll see you again next week on Fertility Fact or Fiction.